There's an overlooked metabolic link between winter cardiovascular events and thyroid function that deserves much more attention than it receives. Thyroid hormones regulate metabolism and cardiovascular function in ways that become critically important during cold stress, yet thyroid dysfunction often goes undiagnosed or is suboptimally treated. Hypothyroidism, underactive thyroid, reduces your body's ability to generate heat and maintain metabolism. When thyroid hormone is insufficient, every cell in your body slows down. This includes your heart muscle, which contracts less forcefully and beats more slowly. In warm weather, this might cause fatigue and weight gain. In winter, it creates genuine danger. When someone with hypothyroidism is exposed to cold, their body struggles to compensate. Unable to generate adequate internal heat, compensatory vasoconstriction becomes more extreme. Blood vessels clamp down tighter, blood pressure rises higher, and peripheral resistance increases more than in someone with normal thyroid function. Thyroid hormones directly affect cardiac contractility, heart rate, and vascular smooth muscle. These aren't indirect effects. Thyroid hormone receptors exist on heart muscle cells and vascular smooth muscle cells. When thyroid hormone is low, these cells don't function optimally. Low thyroid function increases LDL cholesterol, the bad cholesterol that builds up in arteries. It also increases homocysteine, an amino acid that damages blood vessel linings and promotes atherosclerosis. Both of these contribute to cardiovascular disease risk independent of other factors. Winter may unmask subclinical thyroid dysfunction that doesn't cause obvious symptoms in moderate weather. When cold stress demands maximum metabolic capacity, a thyroid functioning at 70% reveals its inadequacy. Symptoms like fatigue, cold intolerance, and difficulty concentrating might have been attributed to winter blues or aging, when actually they indicate thyroid dysfunction. Women over 40 have particularly high rates of undiagnosed hypothyroidism, overlapping significantly with cardiovascular risk profiles. The combination of approaching menopause, declining thyroid function, and accumulated cardiovascular risk factors creates a dangerous convergence. Autoimmune thyroid disease, like Hashimoto's thyroiditis, has additional cardiovascular implications. The same autoimmune inflammatory process that attacks the thyroid also promotes vascular inflammation and endothelial dysfunction. This creates cardiovascular risk beyond what thyroid hormone deficiency alone would cause. Testing makes sense for anyone with unexplained winter fatigue, cold intolerance, or cardiovascular symptoms. TSH, thyroid stimulating hormone, is the screening test, but it's not perfect. Some people have normal TSH but low free T3, the active thyroid hormone. Comprehensive thyroid panels provide better information. Optimal thyroid hormone levels for cardiovascular protection might differ from levels that prevent overt hypothyroidism. The reference ranges for thyroid tests are wide. Someone at the low end of normal might benefit from treatment, especially if they have cardiovascular risk factors. Medication absorption can be affected by cold weather. Levothyroxine, the standard thyroid replacement, should be taken on an empty stomach for optimal absorption. Cold weather constipation, common in winter, might affect medication absorption. These subtle changes could mean previously adequate dosing becomes insufficient. Seasonal dose adjustments might benefit some people. A slightly higher levothyroxine dose in winter compared to summer could maintain more stable cardiovascular function throughout the year. This requires physician guidance and monitoring, not self-adjustment. Dietary iodine and selenium requirements matter for thyroid function. Iodine is the building block of thyroid hormone. Selenium is required for converting inactive T4 to active T3. Winter dietary changes might affect intake of these crucial nutrients. The thyroid cardiovascular connection requires integrated treatment approaches. Endocrinologists and cardiologists should collaborate for patients with both thyroid and cardiovascular issues, yet they often work in isolation. Optimizing thyroid function might reduce cardiovascular medication requirements and vice versa. Monitoring protocols for people on both thyroid and cardiac medications need to account for interactions. Beta blockers can reduce conversion of T4 to T3. Amiodarone, a cardiac rhythm medication, dramatically affects thyroid function. These interactions require thoughtful management. The bottom line is that thyroid function deserves consideration when evaluating winter cardiovascular risk. If you have unexplained cold intolerance, fatigue, elevated cholesterol despite treatment, or cardiovascular symptoms that worsen in winter, ask your physician about thyroid testing. The connection between metabolism, temperature regulation, and cardiovascular function means thyroid optimization could be a crucial but overlooked component of winter cardiovascular protection.